All right, good morning. Welcome to Grand Rounds. My name is Mary Leonard. I'm chair of the department. Delighted to be here in person. The food is wonderful. Ryan, our chief resident, sent a picture out to the house staff to get the word out. We have really lovely breakfast, so start coming in person. Yay, Ryan. Okay. So really thrilled to welcome you to Ground Rounds this morning. For added emphasis, really delighted to welcome you to Ground Rounds this morning in a very special Ground Rounds in honor of Hispanic Heritage Month. But first, we'll dispense with some of our announcements. Great debt of gratitude to our Grand Rounds committee for the lineup of people that they've been bringing through. And next week, we're going to hear about growing the diverse pediatric workforce, fostering the inclusion of residents with disabilities. So looking forward to that. Want to make sure you know about CME and MOC credit. So you can text the code here. For folks that aren't here in person, we'll make sure that that information is in the chat, and then as well as the opportunity to get MOC credit as shown here. And then the Office of CME sent us a bunch of slides about different sort of enduring content on the CME website. So we'll be sharing those with you. This particular one is a discussion about COVID vaccines.
Well, good morning, everyone. And let me just say, it's such an honor and privilege. Baraka, I've known Baraka for many years, and we got a chance to speak several months ago. And she's been talking about all the great work that's being done at Stanford around DEI. And, you know, one of the things I truly love about Stanford is reaching out to colleagues across the country and say, why don't you come by? Let's have a conversation. California has a huge population of Hispanic Latinos. I'm like, you do have a huge population, but New Mexico has the largest population proportion of Latinos, Hispanics in the country, with close to 50%. So I just want to thank, again, Baraka for inviting me and you know, not only being here today, but also having gained incredible mentorship and sponsorship from Dr. Mendoza, and also having had many chances to work with Dr. Yamani and Dr. Thomas at your institution. As I thank many people, I want to thank Dr. Paul Hunter, who's a colleague from the Association of American Medical Colleges, and Dr. Ellis, who helped me with this presentation. So this might be a little bit different than other Grand Rounds presentations in a couple of ways. One, I am not a pediatrician. Right? I am an ER physician who did get some training in Peds ED, right? Did not do a fellowship, but primarily care for adult patients. And in my current role, I'm primarily non-clinical. So that might be a little bit different. But one of the things I definitely want to point out is you have a great family here. So last night, I got to meet some of your residents and fellows, many of your leaders, and we had a great time at Indo, right? So I guess I just want to share this to say, some of you may have missed out. Definitely next time, join us. I also wanted to acknowledge, and I think you probably know, Dr. Padilla over here, as well as Dr. Galvez, who's in the top left-hand corner, who are Stanford alumni and just have led a national social movement, right? And I think this is important for all of us to be aware of with the launch of National Latina Physician Day, which occurred on October 1st this past year. And, you know, I wanted to take a pause and recognize them as Stanford alumni, but also get perspectives, right? The other thing about this Grand Rounds is I enjoy things being interactive. So I have a lot of slides. Those slides are going to be shared, but I want to hear your thoughts and reflections on many things. And I just wanted to point out some of the outcomes that emerged from them hosting and creating this day that was really just conceived, I believe, in June over the summer. But from their work after the launch, they had 14 million views on Twitter, 122,000 interactions, 58,000 likes, 3,000 shares, 345 plus Instagrams, and 13,000 TikTok views. I'm just trying to reach 1,000 followers on Twitter. So I've been asking them, how do you do this? But why do you think it was so impactful? I just want to hear from all of you. Why do you think it was so impactful in terms of the launch of this day on October 1st? why was there so much social media engagement?
Because it was time.
Okay, what do you mean by that?
Can you repeat it for people on Zoom?
Sure, I'm sorry. Why does those people on Zoom, why do you think that Dr. Galvez and Dr. Padilla had such an impact? And Dr. Mendoza said it was time. Thank you, Dr. Leonard. What do you mean by that? What do you think it was time? What does that mean?
The fact that we're such a large population, and I think people feel that something needs to be done for their health. And these are leaders by being physicians. So I think that's why we had such a large following.
Great, great. So thank you, Dr. Mendoza. So, to that point, that it's time. So when we talk about population demographics, which I think many of you are very much aware of, the community that I often refer to as LHS Plus, which is a new umbrella term, which stands for Latina, Latino, Latinx, Latina, Hispanic, or Spanish origin, and I'll go into the plus shortly, now is the largest non-white racial ethnic group in the United States, and that's been the case for a couple of years now. And we know in many of our states, Hispanic Latinos may represent the majority of students in our schools, or the majority of non-white racial ethnic students. So I'm just going to review some of the numbers of what LHS Plus identity looks like within our clinical and academic medicine workforce, review some factors that influence LHS Plus inclusion within academic medicine, which is my particular focus area, and then review assets, right? Because sometimes we talk about the numbers, which can be very concerning, but then what do we do about it? So what you can see here represented is sort of what I already mentioned, that in terms of the LHS Plus community, we're close to 19% across the country. And you can see the representation within that group by national identity, with Mexicano, Chicano being the largest proportion of the community, with 37 million individuals who identify as Mexican identity, followed by Puerto Rico. Both my parents were born in Puerto Rico, and then Cuban, and cascading down the LHS Plus diaspora. Another thing that I wanted to just give special mention to is how people identify. And I think there's been a lot of discourse within our academic community as to whether we identify as Latinx or Hispanic or Latino or Latina. But I would argue that Latinx is really more of an academic term. Across the country, most community members identify as Hispanic, Latino, Latina, or of their national origin. And of course, the way we identify as community members really ties to what generation we're a part of within the United States. We're foreign-born individuals or first generation, identifying more closely with Hispanic, Latino, Latina, or a national identity. And as the generations go along, you see a greater proportion identifying more with the term American. So the introduction of this new term, LHS Plus, is really to bring people together. I'm amazed that sometimes learners and faculty will have disagreements, whereby sometimes learners will only feel included is if we use the word Latinx, right? And as we want to create a space for everyone to self-identify, we want to create a term that is inclusive of the different terms in the community. So LHS Plus, as an umbrella term, is reflective of common geographic upbringing, whether in the Caribbean, North, Central, or South America, or Spain, as well as Spanish language ancestry. It's a recognition of historical terms that you'll often see on AAMC or ACGME surveys or the GQ, as well as emerging generational or non-binary terms like Latinx or Latina. And E really represents a sort of non-gender identity, with the plus acknowledging other terms which also come into play, such as national identity, Afro-Latin, Nuyorican, for those individuals like myself who were born in New York City and also acknowledge their Puerto Rican heritage. Similar to racial categories, it's not a biologic term, right? These are all social constructs. All racial categories are social constructs that are very powerful in terms of bringing individuals together. And it's sort of comparable to LGBTQ+. For those individuals who are part of the LGBTQ+ community, remember that often terms like gay was a unifying term. And then women would say, wait a minute, I'm lesbian, right? I don't identify with that. And it moved from gay to gay and lesbian, and then other groups felt excluded, creating the new term of LGBTQ+ or SGM. So when we think about the LHS+ community, not only within our physician workforce, as we work with our colleagues through a team-based approach, you'll see, based on this slide from HRSA, that Hispanic, Latinos, LHS+ individuals are really markedly underrepresented across many health professions. And here you could see, this is a little bit outdated, but hasn't really changed much, that physicians of LHS+ identity are 6%. And then you can see pharmacists at 4%. So as mentioned, currently approximately 6% of US physicians are LHS+ identity, with a very large proportion, the majority, having been born outside of the United States, which to me is an important reflection, right? When you think about it, how is it that the majority of LHS+ physicians are foreign-born? And what does that say about our ability to educate our own who were born and raised here to succeed in the journey to becoming health professionals? Here is a little bit of transition within the area of academia, and you see a breakdown of different ranks: professor, associate professor, assistant professor, and then also compared by gender and also race, ethnicity, where you see, I just mentioned that 6% of physicians are of LHS+ identity, and there's a little bit less of our faculty across allopathic medical schools. And we look at osteopathic medical schools, which I'm going to show shortly, it's even lower. Here, it's just pointing out what I'm already mentioning, the low proportion of LHS+ faculty by sex and race and ethnicity as reported by the AAMC in 2021. Once again, just by different ranks across. And, we are hopeful because there is a higher proportion. But I think, when I look at my own career of now being a full professor with tenure, the number of LHS+ individuals, full professor with tenure, is probably like 1.5% out of all full professors with tenure. And then in terms of osteopathic granting institutions, it's even lower. So just in summary, US population is currently 19% LHS+, with 13% of our allopathic medical students across the country. LHS+, only 7% of osteopathic medical students, close to 8% of residents, and then 6% of practicing physicians. I know that Stanford has been very successful in recruiting diverse medical students. Lahia was sharing with me the great accomplishments and her efforts, and I want to congratulate her on having supported close to 30% of residents now being of racial ethnic minority status. But I think one of the questions that many departments or leaders in the DEI world still grapple with is when senior leadership says, well, we're not doing bad. We're at the national level, right? 8% of residents across this country are LHS+. 8% of our residents or 6% of our faculty are LHS+. We've done it, right? We're at the median. Do we have to do anything more? I think the question or the thought process for those people in the community is what's going to best serve our population of patients? Does parity matter? Does it matter to have physicians who are bilingual, who understands the customs, the beliefs, the dietary habits of your community? If your community is 40% LHS+, or in the state of New Mexico is 50%, then what are we aiming for? Are we aiming for 8%? Are we aiming for something higher? Why does it make a difference? And here, not surprising, there's a higher proportion of LHS plus individuals on the lower ranks than in the higher ranks. Also, this is a slide that just gives a glimpse of LHS plus identity. This is from the AAMC, just from allopathic medical schools, the 155 allopathic medical schools across the country. And you'll see amongst all pediatric chairs, five are LHS plus women and 5 are LHS plus men. And our chair of pediatrics at UNM, Dr. Loretta Cordova de Ortega, is, I believe, the first Latina chair of any pediatrics department. And here is another slide from the AAMC, which looks at the progression of women and URM deans at allopathic, right, MD granting medical schools across the country. And you could see maybe at moments there was a little bit more or less, but it really hasn't changed much since 1992, right? It hasn't changed much irrespective of the explosion of medical schools that have occurred over the past 20 years, right? And I say that because, you know, new medical schools don't have the same history of older medical schools, right? So new medical schools really do have the opportunity to create something different, but that's not happening either. It's not happening at the old medical schools or the new medical schools. And I say that because in my mind, and I'll ask you all, what is the most, what has probably been the most effective approach to increasing African-American Black medical students in this country? And it ties to what I was just talking about, the status of medical schools. That's right, HBCUs. Is anyone from Morehouse, Meharry, Drew, right? If you think about HBCUs, they are the largest producer of African-American and Black medical students by far, if not only by graduating them, but close to 60% of African-American and Black current physicians have a touch point in an HBCU. They went to college there, their legacy of parents who went there and so forth. So if you ask me, an important step to increasing the number of LHS plus and African-American and Black medical students is just to open up more HBCUs and true HSI medical schools, Hispanic serving institutions. Right now, the categorization of an HSI is on the proportion of your students that are Latino or Hispanic. An HSI is not defined as to whether anything more than that is done in terms of integrating curriculum, who's leading your institution, and so forth. So just, I digress, I shifted, but really talking about what might be an effective way. And here's just a reflection of representation, not only by racial ethnic category, but also gender, right? And we've made progress in having more women as our faculty, not at parity yet, but still women are markedly underrepresented in senior leaderships. So why does it matter to have LHS plus in these roles? Full professors, chairs, and deans. This is me asking someone to answer now. Why does it matter? These are great roles, right? I love my role as a executive associate vice chancellor. Why does it matter to have diversity in these roles? Yeah, it feels safer. There's a congruence in sponsorship, mentorship. If I see that you're in this position, I could aspire to be like you. I could say, Dr. Leonard, there's so few women, right? Chairs, like, please tell me about your struggles. What made you successful? Can I learn from you? That's right. And it also breaks the cycle. And Sonia taught me this yesterday, right? It breaks the cycle of mansplaining. Was that correct? Right? I take that back. But we know it happens, right? It happens, right? I'm in trouble now. So here's just another update. This is actually 2019, the number of LHS plus deans across allopathic and osteopathic. So there's 200 medical schools in the United States between allopathic. And in 2019, there were 8 LHS plus identified deans, and now there's 5, right? Any trends amongst these 5? Any trends? If you look at the names of the schools, any trends?
Geography.
Yes. What about geography?
4 out of 5 are Puerto Rico and 1's Florida.
That's right. I'm proud of my people. I'm proud of Puerto Rico. No surprise though, because 99% of people on the island of Puerto Rico are Hispanic Latino, right? So yes, great gender parity. 2-2. We just recently, it was 3-1, 3 women deans, and then 1 man, and now it's 2-2. And 1 of the 4 is gay identified. The only mainland dean is Dr. Sandan at FIU, right? And the other question is not only always presenting numbers, but why, right? Why, irrespective of all of our diversity efforts, we find ourselves in this situation, and why does it matter? And how are we going to change it? And why it matters is because we are fully aware of the unique health issues and health disparities across this country for different groups, right? It is our vision, mission, our strategic plan to address health disparities and to address health inequities. Specifically, we know that Hispanic Latino children and adolescents have a higher prevalence of obesity than their non-Hispanic white and non-Hispanic Asian peers, right? Just to highlight the pediatric statistic here, and a whole other set of factors. So what do you feel are the challenges that LHS plus identified community members face in pursuing medicine and academic medicine careers, right? And pediatricians play a pivotal role, right? You're building our next generation. You have unique contact points with students. You know, we talk about the K through 12 pipeline, right? So pediatricians play a unique role in supporting the K through 12 pipeline. What do you think are the unique challenges?
Money.
What about money?
Depending on their background, they may buy less advantaged groups.
Okay.
If they afford going to take.
Okay, great. So they may not have been afforded the same resources, educational resources, access to educational materials, tutoring, which decreases their competitiveness in a very competitive application process, right? And now with the move to competency-based education, you know, I think that's one way that we're rectifying that. Anyone else? Money?
Status.
Documentation status. That's great. And that also ties to money, right? Now, many medical schools will accept DACA status students, right? But a big challenge for medical students is creating the funding lines, since they may not be able, they can't access federal funds, right? So that also ties to money. What else?
Racism.
Racism. Absolutely. Racism, ethno-racism, right? The social and physical environment that they live in. And are they surviving? Are they thriving? Is anyone saying, you know what? You're really smart. You could be a doctor one day. You could be dean of a medical school or a faculty member. So thank you, Akia. You must have known the next slide. Thank you. Great. So, you know, we can go over a cascade of different factors. It's really multifactorial. We know, and this shouldn't be surprising, that the social environment matters. This was put out by the Hispanic Pew Research Center, which just highlights some of the common forms of discrimination faced by Hispanic individuals in general society, which, to no surprise as well, those individuals of LHS plus identity with darker complexion face a higher frequency and burden of these forms of discrimination, such as being told or feeling like people didn't think that they were smart, being subjected to slurs or jokes, having people make you feel like, you know, they're unsafe when they're around you or suspicious of who you are and your behaviors, being treated unfairly in hiring, pay, or promotion, right? That's something that we always consider. We know, and we've learned from data from the AAMC, that it's not only the discrimination that they're facing in their neighborhoods or in general society, but it's happening in our medical school environments, right? And as you can see here, in 2013, the AAMC conducted a survey amongst all second-year medical students, and they asked students, what is your stress level, your quality of life, your fatigue, level of social support, and financial concerns. And those students who identified as URM reported a higher level of stress and lower quality of life than their counterparts. And when you think about intersectional identity, or when you view our students holistically, individuals who are first generation, female, LGBT, their levels of stress are even further compounded. The other thing, and I think progress is being made by many medical schools, and I bring this up because as learners and faculty and staff who run medical schools, right? You're a part of a department, but you have a great level of influence on the leadership of the medical schools. More medical schools have looked at whether grading disparities exist, especially in third-year clerkships. So that's something that we did at the University of New Mexico. And we learned from like UCSF and the University of Washington, and we looked over 5 to 10 years of grading of our medical students in their third year. We found out that students who identify as African American, Native American, and Hispanic were being graded lower after controlling a number of factors. And what I loved about our institution is the dean accepted it, said, you know what, we failed our students, and now we have to transform things. And so some of the things that we're looking to do is moving away from a tiered grading system, recognizing competency-based education, and now we are pass-fail in our preclinical years, and we're exploring that also for our clinical grading. Some of the unique challenges for medical students of LHS Plus identity in considering becoming future faculty, which is really critical. As I mentioned, only about 5 to 6% of our faculty are LHS Plus, is just self-doubt about being good enough, right? Never being told, you know what, you were smart enough, you're brilliant, you got into medical school. Not being told that they're also good enough to be our learners and teachers, and feeling that disconnect, and therefore not considering it as a career option. Also, lack of information generally about what it means to be a faculty member, lack of competency to succeed in those things that are important for faculty to be hired and promoted, obstacles in the promotion process, and career development resources. So, I love frameworks because often when we think about these things, it's important to look at all these questions from through a holistic lens and view these issues as really being multifactorial. I love this chart. This is a play off of Dr. Sánchez, past US Surgeon General, Dr. Sachser's framework on factors influencing determinants of health, and then Eve Higginbotham, Dr. Higginbotham, who's the Vice President of Diversity, Equity, and Inclusion at UPenn, modified it to determinants of health in academia, right? Applying the same framework. We always think about the individual at the core, in the middle to support. And it's really, viewing their biology, their unique characteristics, not as deficits, but assets to advance health equity, creating a social and physical environment to ensure that they flourish, building equitable policies and interventions, and always access to quality mentors and a robust professional networking, including of sponsorship. So as I say that, I think as we've engaged in this discourse on a national level around racism, what makes it tricky for the LHS Plus community is that Hispanic Latinos are not a race, right? It's an interesting situation, right? Like Hispanic identity, it's a social construct where at some point, some person made a decision to separate it as a category and as a separate question. But for all purposes, many people in the LHS Plus community, I don't have a race. My race is Hispanic, right? I think we're seeing an emergence of literature on how Hispanic Latinos feel like they're being brought into the discussion around isms within our academic setting. And here's just a recent article giving a shout out to Dr. Laura Roberts, your editor-in-chief of Academic Medicine, in which this article has appeared, and having different Hispanic faculty talk about what it's like to survive or thrive within academia. There is a significant need for us to work collectively to increase content on LHS Plus identity within the literature, and just highlighting some recent publications, more so around language equity and medical Spanish. And I think this is important to report. I know in the state of New Mexico, 28% of our children speak Spanish at home. And I know growing up, Spanish was viewed as second to English. Actually, often we were told, don't speak Spanish because that's not going to let you excel on your exams, right? But I think now we've moved away from being bilingual, being a deficit, to more of an asset. And I'm grateful for colleagues like Dr. Pilar Ortega, who is now associate editor, guest editor for a new collection embedded portal on language equity. And this is just an example. So as faculty and students are running these medical Spanish clubs at many of our schools, this is a unique opportunity to take their work and publish it and disseminate it across the country. Here's Dr. Ortega and Dr. Silva, who are the new guest editors for this new collection. So I encourage you to submit content to it, but also download the materials to enhance your medical Spanish programming. Just some other things to highlight as resources through the Latino Medical Student Association, which Baraka had mentioned. And I just want to take a moment because I want people to think about, why did an organization like the Latino Medical Student Association or the Student National Medical Association or the American Medical Women's Association or APAMSA, Asian Pacific American Medical Student Association, need to come about? Like, why did it matter for all those organizations to come about and still exist if our medical school environment is perfect or ideal, right? So LMSA has celebrated 50 years, and these organizations exist to help remind medical schools of what they still need to do to ensure an equitable environment. So LMSA is a partner member of a National Center for Pre-Faculty Development, which Stanford is also a member of. And it's really to encourage more of our diverse trainees to become future faculty and leaders, affording networking, sponsorship opportunities, sharing best practices across 25 institutions, and building those communal relationships. The National Center with LMSA and SNMA and APAMSA and the Medical Student Pride Alliance have contributed to 2 books. And I'm just, highlighting them here. One is Health Professions in Academia, as mentioned before, and Succeeding in Academic Medicine. Because often people say, like, what are the resources that we could provide to students, college students, right? Health Professions in Academia is for high school and college students, right? To encourage them to become health practitioners, as well as consider faculty and senior leadership careers. And here are 2 resources, right? And I encourage you to create more resources. I mean, both of these are my books, right? Like, so clearly, but I love when people say, JP, I don't agree with what you wrote in that book. And I'm like, great, write your book. You have a different perspective, send me your book, right? And that's what we need to do, right? We need to create the materials that we want to use in the K through 12 programs. And here are some of the, so this is what I'm hoping academic medicine will look like in the future with the diversity that we don't currently see. I'm just gonna jump over some slides. LMSA did launch recently a National Center for Leadership and Advancement. So this is another resource to really ensure that our LHS Plus faculty are given the appropriate guidance and support to succeed, right? The AAMC put out a report several years ago on altering the course of Black men in medicine over 40 years. Did anyone read that report? Altering the course of Black men in medicine, a 40-year perspective, where they said that over 40 years, the number of Black men in medicine has decreased every year over 40 years. You can publish anything right now. When you can slap yourself on the back and put out a report and say that I didn't look at the numbers over 40 years and say, guess what? the number of Black men in medicine has decreased every year for 40 years. We have a big problem. And not really look at the underlying factors or address it differently. So the LMSA National Center for Leadership and Advancement is saying, oh, we're gonna work to make sure that doesn't happen to the LHS Plus community, right? And so some of the things that, I think the group, has done well is, doing those little things like getting every dean of a medical school across this country to congratulate LMSA to know, oh, I know the problem, right? I acknowledge that 6% is not enough, right? Which was the big focus of the National Latina Physician Day. 6% is not enough, and really thinking about what they're going to do in their role as a dean to incorporate it into their strategic plan and work towards a different goal. It's not about saying I have a value, a vision, a mission. It's about having goals, right? We have goals on the department level. I got to balance my budget. I got to make sure that every clinic is well staffed. People are being hired all the time in our hospitals and schools of medicine. So it's like, okay, it's 6%. So what is the goal at Stanford? What is the goal? Is there a goal? What's the goal at Stanford?
30% across all roles by certain year.
2030.
2030? That's excellent, right? That is excellent. Many schools don't have goals. 30 by 30. 30%. You know why? Because not everyone is responsible. Everyone is responsible, right? Because when the chairs are held responsible, guess who's responsible next? Who's responsible next? You all, that's right. The chair is going to be like, oh, we got to do this. How are we going to do this? Let's figure it out, right? Every chief, every vice chair, every faculty member, go out there. Tell all your patients, you can be a doctor. You can be a doctor. I need you to apply before 2030 because we need to reach 30%. How old are you? You could do it at 15. You could do it at 15. We're going to figure it out. So, goals. LMSA has goals, right? My goal is that no medical student feels alone. No LHS Plus medical student, resident, or faculty member feels alone, right? Because we know that mentorship and sponsorship matters. We are close to having an LMSA chapter at every allopathic medical school. By December, Fernando, I expect we're going to reach 100%. We're at like 90% now. And osteopathic, we're working on it, 36, but I'm hopeful by December. They have 40 medical schools, so it'll be a little bit easier. And just want to highlight some of the programs for, Latino faculty, just like there's programs. So one of the things that I'm going to be mindful of time, I'm going to do a couple more slides in the next 2 minutes and then open it up for any questions or thoughts, is that when I run into students or residents and faculty, they'll say, Dr. Sánchez, like there's no program for me. And I'm like, really? There's no program. There are programs everywhere. Just like there's pipeline and pathway programs to pursue the health professions that are tailored for racial ethnic minorities, for individuals of STM identity, for women, there's emerging professional development programs for junior, mid-career, and senior faculty, right? AAMC has women's early career, women's mid-career, women's senior leaders, right? Similarly, for racial ethnic groups, there are also similar programming through your pediatric associations. And I know Dr. Mendoza has been extremely, active in promoting it in the pediatric community. And LMSA also has created programming for faculty, right? Residents, junior, mid-career, and senior. So I think we're living in a time that there's more formalized programming. Now it's about connecting people to these programming, right? So I ask you to send, your trainees, your junior, mid-career faculty to these programs so they develop those networks. I will this is the last thing I'll leave you with, that as you're engaged in recruiting residents to your medical students, to your residency programs, the AAMC recently put out a letter an email saying that the students from Puerto Rico are not international. It is true, since 1898, after the Spanish-American War, Puerto Rico came under the United States as a Commonwealth, and students from Puerto Rico are part of the LCME system, but an email is not enough, right? So LMSA, just acknowledging this as one issue to diversifying the residency workforce, the faculty workforce, created a survey. And what we found out is that students, Latino students and Puerto Rican students in particular from the island, are feeling like they're at risk of being denied when they apply to certain GME programs because of where they went to medical school. Because they go to medical schools in Puerto Rico, they're being treated differently. They're being asked if they speak English and so forth. So this is just an example of the unique experiences that some of our students, our LHS Plus students, deal with. DACA students also have unique challenges and deal with unique form of discrimination when they apply. And then also when you think about dual identity, being osteopathic and LHS plus and so forth. So just important as we're in the GME cycle to think about this and to be really proactive in addressing these issues, like I mentioned, in addressing grading disparities in third-year clerkships, or in follow-up when AAMC sends out emails of how students are being mistreated. What can we do differently beyond an email, right, when we're inundated with email? So LMSA has taken the role of completing surveys or conducting surveys to better understand the process, meeting with deans' leaderships, creating educational materials and so forth. So with that, this is my last slide, just as a reminder, and congratulations again to your Stanford alumni for really shaking up the country on Saturday, October 1st, right? With the launch of this day and saying 6% is not enough. And the sad reality is it's not only in the 6% of our faculty, of our physicians, but also the 6% of faculty who are LHS plus. So with that, I want to thank you for your attention and just open it up to any questions. Thank you.
Thank you so much for that wonderful talk. Hi, I'm Jen. I'm one of the 4 chief residents, Peds residents here. We really appreciate you coming and talking to us. One of the things that I found so striking, one of the numbers in your presentation, as recruitment season is upon us and we're focusing on who we're bringing into our next class, was that numerical difference between 13% LHS plus allopathic medical students, and then I think it was a drop to 8% of residents. That seems like a huge differential there. Is this having to do with matriculation out of medical school, or is this that gap between recruitment into residency from medical school? You offered some great suggestions as to things we can be doing for recruitment, but if you have any other thoughts or advice for us as we enter into that season and try to close that gap, I'd really appreciate it.
Yeah, no, absolutely. So allopathic is about 13%. Osteopathic is less when you combine it. It's about 11% of osteopathic and allopathic or LHS plus. Remember that a significant proportion of your residents across this country are also IMG. So those proportions are reflection when I said allopathic medical students, right? But the resident proportion includes international medical graduates that would have, depending, a lower proportion of LHS plus identity. So that's why you see that difference. I mean, I guess going to that point, on the national level, what's the proportion of pediatric residents that are LHS plus, and what is the goal of pediatric associations, right? Because that would, I don't know if anyone knows that.
But I don't remember the exact for LH plus, but recently when we did a study looking at the data for pediatric residents and fellows from like 2007 to 2019, it essentially did not change, but it was about 16.5% across URM.
Okay.
So unfortunately, the pipeline hasn't changed for 40 years. And part of this is the thing that you brought up, is who's saying to the youngsters, you can be a doctor. And I think that the critical role of pediatrics is to pose that question. At the end of the day, the school systems are under-resourced. And one can see that even more so now in the post-COVID area, because we have a lot of kids that have lost more because they didn't have Wi-Fi and other things. So the agenda for the country, particularly for California, where half of all the children are Latino, is to say to them, you could be a doctor. And even though they have obstacles to overcome, if they never get told you can be a doctor, they will never be doctors. And that has been, unfortunately, the history of our nation for not just those that are Latinx, Latino, Hispanic, but African American, Native American, and even some populations of Asian Americans. So I think we need to take to heart that issue of saying to them, you can be a doctor.
And along those lines as well, historically, most racial, ethnic, minoritized medical students were told, we need you in the community. Go be a community doctor, right? And they weren't told, you know what, we also need you to be a faculty member. And you could do both, right? You could be a part-time, you could be a volunteer faculty member or full faculty member and still serve your community.
I would just add, Stanford did that in Stanford started that with a program called the Early Matriculation Program in 1984. And that now has produced not just professors across the country, but our Dean of Admissions here is from that program. So at the end of the day, the statement of leadership development is really key to this agenda.
You're going to say it, we'll repeat.
Okay. So I was just going to say to the fact saying about doctors, that also ties into my representation mechanism, because you are able to looks like you.
Do you want to repeat it?
Yeah, I think synopsis is representation matters and how powerful it is to, again, for us in pediatrics, tell kids you can be a doctor. What do you want to do? And when it is coming from someone that looks like you, that is really powerful.
Right. What does it cost to tell a kid, you know what, you're smart enough, we need you to be a doctor? It doesn't cost money.
Well, I just want to thank you so much. It was really, really a pleasure to have you here. And I want to ask, can we have your slides and post them?
Yes.
Because that's a tremendous resource. We always post the video, but we'll post your slide as well. I have some follow-up questions for you. We're piloting in the Department of Peds something called PRESS, something pediatric research experience in the subspecialties at Stanford. We're trying to bring in URM residents to do an elective with us with the hope that they'll do their fellowship here. So we'll want to talk to you about how to do
that's
some
amazing.
outreach around that as well, building on the program that's been very successful, SCORE, which is the medical students that, you know, has been in place for a long time, bringing medical students here with the hope we'll get them in residency where we have this phenomenal diversity, but we have a long ways to go on our fellowship. So that's the next frontier.
And
So-
I just also want to say that everyone has spoken about Dr. Leonard, Chairperson Leonard's advocacy and advancing DI, right? And I want to give that shout out so the other chairs follow suit,
A little peer pressure.
right?
There we go.
Absolutely. So you need, right? And this has come not only from people in your department, because then I'm like, oh, that's a setup, right?
Yeah.
But when you have people in other departments and senior leaders, I want to say thank you for your leadership. And let's tell the other chairs now.
All right, good. Thank you for joining us.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.